At the conclusion of this presentation, participants should be able to identify the general categories of male infertility, distinguish between congenital and acquired causes of male infertility, and discuss the etiology of the most common causes of male infertility.
Infertility affects about 6.7 million women and their partners in the U.S., about 11% of reproductive age population. A male factor is solely responsible for infertility in 20 to 30% of couples and contributes 50% of cases overall. Male infertility can be due to a variety of conditions, some of which can be identified and corrected, while others can be identified but not corrected. When the male has an abnormal semen analysis, for which the cause cannot be identified, the condition is termed idiopathic.
A male factor is almost always defined by abnormal semen parameters. However, a male factor may also be involved when the semen analysis is normal. A male factor may be due to hormonal abnormalities, resulting in decreased sperm production, abnormalities of testicular function, or abnormal sperm transport or delivery. Causes of male infertility associated with normal sperm production include poor coital technique, erectile dysfunction, and ejaculatory disorders. Chromosomal abnormalities are a congenital cause of male infertility. Y chromosome microdeletions are found in 10 to 15% of men with azoospermia, when there's no sperm present in the semen, and severe oligospermia, defined as less than 5 million sperm per milliliter. This condition involves the long arm, YQ11, of the Y chromosome. There are 3 regions: azoospermia factor AZFA, AZFB, and AZFC. Deletion of the entire AZFA or AZFB region results in azoospermia. Men with AZFC deletions may have azoospermia or produce very limited numbers of sperm, resulting in oligospermia. Noonan syndrome is sometimes referred to as male Turner syndrome and has autosomal dominant inheritance. Defects in 4 genes, KRAS, PTPN11, RAF1, SOS1, affect proteins involved in the proper formation of several types of tissue during development, including sexual organs. Individuals with Noonan syndrome typically have unusual facial characteristics, short stature, heart defects, bleeding problems, skeletal malformations, and eye abnormalities. Most with Noonan syndrome have normal intelligence, but puberty is usually delayed, and most males have undescended testicles and diminished spermatogenesis. Noonan syndrome is sometimes referred to as male Turner syndrome and has autosomal dominant inheritance. Defects in 4 genes, KRAS, PTPN11, RAF1, SOS1, affect proteins involved in the proper formation of several types of tissue during development, including sexual organs. Individuals with Noonan syndrome typically have unusual facial characteristics, short stature, heart defects, bleeding problems, skeletal malformations, and eye abnormalities. Most with Noonan syndrome have normal intelligence, but puberty is usually delayed, and most males have undescended testicles and diminished spermatogenesis. The most common sex chromosome disorder is Klinefelter syndrome, which is due to the presence of an extra X chromosome. 47XXY, and occurs in about 1 out of every 1,000 males. Men with Klinefelter syndrome have high follicle-stimulating hormone, FSH, levels and may have low testosterone levels. They characteristically have small, firm testes and azoospermia. While some men have bilateral gynecomastia, breast enlargement, delayed puberty, and a female body shape with relatively long legs, many men appear normal but only have small testes and infertility. Some men have a mosaic pattern on karyotype, 47XXY, 46XY, and may have oligospermia. Many other genetic abnormalities, such as chromosome deletions and translocations, may also cause infertility. The 46XX male is rare. Although the karyotype is female, individuals are phenotypically male, with male externogenitalia ranging from normal to ambiguous, to testes, azoospermia, and absence of Müllerian structures. These men are infertile. A number of genetic abnormalities result in male infertility. In congenital bilateral absence of the vas deferens, or CBAVD, the vas deferens do not develop. Many men with CBAVD also lack much of the epididymis. This means sperm cannot pass from the testes into the ejaculate. However, there is normal testicular function. Congenital bilateral absence of the vas deferens is caused by a mutation on the CFTR gene, cystic fibrosis transmembrane conductance regulator, on chromosome number 7. CFTR functions as an ion channel across the cell membrane and is the same gene involved in cystic fibrosis. All men with cystic fibrosis have CBAVD, and 80% of men with CBAVD have documented CFTR gene mutations. Congenital bilateral absence of the vas deferens results in obstructive azoospermia, which is non-reconstructible. Other genetic abnormalities include myotonic dystrophy and congenital deficiency of testosterone production. Myotonic muscular dystrophy is an inherited disorder of progressive muscle degeneration. It has an autosomal dominant pattern involving chromosome 19 and is the most common form of muscular dystrophy that begins in adulthood. The condition causes hypogonadotrophic hypogonadism with elevated FSH and luteinizing hormone, LH, with low testosterone. These men experience atrophy of the testicles and reduced fertility. Congenital deficiency of testosterone production is a rare disorder that is caused by a lack of genes that encode for enzymes needed for androgen biosynthesis. There is incomplete virilization in affected men. Developmental abnormalities include Sertoli cell-only syndrome, also known as germ cell aplasia. In this condition, there is a congenital absence of germ cells in the seminiferous tubules of the testes due to failure of migration during embryonic development. As a result, only Sertoli cells line the seminiferous tubules of the testes. A pattern of Sertoli cell only can also be acquired as a result of exposure to chemotherapy or radiation therapy that destroys the germ cells. Some men with Sertoli cell only have small pockets of sperm production within portions of the testicle, which can be retrieved by testicular sperm extraction. In cryptorchidism, there's a failure of the testes to descend into the scrotum. It is the most common birth defect of the male genitalia. In boys born at full term, the cause is usually unknown. A about 30% of men with unilateral cryptorchidism, and about 50% of men with bilateral cryptorchidism will have oligospermia. Fertility rates are worse in men with bilateral cryptorchidism. A varicocele is an abnormal dilation of the veins of the pampiniform plexus in the scrotum. It is usually left-sided, but may be bilateral. Varicocele is present in 15% of all males and in 40% of infertile males. Varicoceles have a progressive, deleterious effect on spermatogenesis. This is the most common correctable cause of male infertility. Ejaculatory duct obstruction can be congenital or acquired. Congenital duct obstruction is due to compression and obstruction of the ejaculatory ducts by cysts within the prostate, such as Müllerian duct cysts or ejaculatory duct cysts. Acquired obstruction may be due to infections such as prostatitis or epididymitis, or related to prior urethral surgery. The obstruction can be partial or complete with azoospermia. Ejaculatory volume is low. Ejaculatory duct obstruction can be diagnosed by transrectal ultrasound and is treated by transurethral resection of the ejaculatory ducts or unroofing of the prostatic cyst. Hormonal abnormalities also contribute to male infertility. Isolated gonadotrophin-releasing hormone, GnRH, deficiency will result in infertility. Some patients lack GnRH production and lack the nerves enabling their sense of smell, called anosmia. Hypogonadotrophic hypogonadism associated with anosmia is referred to as Kallmann syndrome. Patients with GnRH deficiency do not produce LH and FSH, with resulting azoospermia. Gonadotrophin replacement therapy can reverse the azoospermia. Abnormalities associated with Kallmann syndrome include anosmia, cryptorchidism, and gynecomastia. Isolated LH deficiency is also known as fertile eunuch syndrome. This is a variant of Kallmann syndrome where enough FSH is produced to induce spermatogenesis despite incomplete sexual development. Isolated GnRH deficiency also results in two other syndromes associated with male infertility. Prader-Willi syndrome is a complex genetic condition that involves the loss of genes in a specific region of chromosome 15. It results in low levels of FSH and LH, hypotonia, obesity, mental retardation, and short stature. Lawrence-Moon-Beadle syndrome, or Lawrence-Moon syndrome, is a rare inherited disorder characterized by diminished hormone production by the testes, hypogonadism. Affected individuals have microphallus, hypospadias, undescended testes, and obesity. Other hormonal abnormalities in males include mutations of the GnRH receptor, LH beta, or DAX1 genes. In these rare conditions, GnRH release does not stimulate LH secretion by the pituitary. DAX1 mutation leads to congenital adrenal hyperplasia. Increased adrenal androgens suppress LH and FSH production. Multiple hypothalamus and pituitary hormone deficiencies also result in male infertility. Androgen insensitivity syndrome, or AIS, was formerly known as testicular feminization. In this condition, there is a defect in the androgen receptor gene, which results in lack of androgen receptors, a defect in receptor function, or post-receptor defects. Individuals with androgen insensitivity syndrome are genetic males, 46XY, but have a female phenotype. Testes are undescended, there's a lack of pubic hair, and the proximal vagina, uterus, and tubes are absent. The condition affects 2 to 5 per 100,000 people who are genetically male. Acquired causes of male infertility include autoimmune damage and the production of anti-sperm antibodies. The blood-testis barrier is a physical barrier between the blood vessels and the maturing sperm within the seminiferous tubules of the testes. Connections between the Sertoli cells form a tight barrier that prevents genital injury can adversely affect sperm production or sperm transport and may also lead to anti-sperm antibody production. Scrotal surgery can inadvertently lead to ductal obstruction. Retroperitoneal surgery can injure the nerves responsible for seminal emission.
Inguinal hernia repair may result in basal occlusion.
In testicular torsion, there is a twisting of the spermatic cord, which cuts off the blood supply to the testicle. As a result, sperm production may be impaired and anti-sperm antibodies may form. Infections and sexually transmitted infections can result in tissue damage and ductal obstruction. Common infections include orchitis, bacterial or secondary to mumps, epididymitis, may be due to chlamydia or bacterial, and prostatitis.
Scrotal, heat exposure, radiation, and chemotherapy also contribute to male infertility.
Acquired ductal obstruction may be due to infections in the epididymis and ejaculatory ducts, or from surgery, including vasectomy, radical prostatectomy, and transurethral resection of the prostate, TURP. Systemic illnesses can also lead to male infertility. Acute and chronic illnesses, including burns, sepsis, myocardial infarction, MI, cirrhosis, renal failure, diabetes, spinal cord injury, and acquired immunodeficiency syndrome, AIDS, anorexia, and obesity are also contributors to male infertility.
Obesity and age has been associated with reduced semen quality and hormone alterations and may increase the risk for erectile dysfunction.
Medications and drugs of abuse also are factors in male infertility and include alkylating agents used in chemotherapy, ionizing radiation, ketoconazole, exogenous testosterone supplementation, illegal substances including marijuana, opiates, and heroin, and legal substances such as alcohol and tobacco, which have effects on male fertility. Excessive alcohol use can interfere with testicular function and male hormone production, resulting in impotence, infertility, and reduction of male secondary sex characteristics, such as facial and chest hair. Tobacco use adversely affects sperm. The effect is worse in men who also have a varicocele. Ejaculatory disorders are also acquired causes of male infertility. In retrograde ejaculation, semen enters the bladder instead of passing out through the urethra during ejaculation. Anejaculation is the term for the inability, either physical or psychogenic, to ejaculate. Causes of ejaculatory disorders include post-surgical changes such as after prostate surgery or a retroperitoneal lymph node dissection, RPL-ND, performed to treat metastatic testicular cancer, neurological alterations such as in diabetes, spinal cord injuries, and medications such as alpha blockers for treatment of high blood pressure, and some prostate conditions. Psychological factors can cause premature ejaculation. Erectile dysfunction, or ED, has become a well-known condition in recent years. It is the inability to achieve or maintain an erection suitable for sexual intercourse. ED can be a total inability to achieve erection, an inconsistent ability to do so, or a tendency to sustain only brief erections. Erections begin with sensory or mental stimulation, or both. Impulses from the brain and local nerves cause the muscles of the corpora cavernosa to relax, allowing blood to flow in and fill the spaces. The blood creates pressure in the corpora cavernosa, making the penis expand. As the tunica albuginea expands, it compresses exiting veins to help trap blood in the corpora cavernosa, thereby sustaining the erection. Development of an erection requires intact psychological, neurological, and vascular mechanisms. Physical causes of erectile dysfunction include cardiovascular disease, diabetes, neurologic disease, and hypogonadism. Psychogenic causes include depression, anxiety, and stress. Medications also affect ED, especially antidepressants and drugs to treat hypertension. Certain hormonal abnormalities can be acquired causes of male infertility. Increased estrogen or decreased testosterone to estrogen ratio is associated with impairment of sperm production. Gynecomastia is the development of glandular breast tissue in men that results from estrogen-testosterone imbalance. It may develop with increased estrogen secretion in puberty or after treatment of severe illness or tumors of the liver or testes. Increased peripheral conversion of androgens to estrogen can occur with obesity, hyperthyroidism, and cirrhosis. Inhibition of androgen binding may be due to medications such as spirolactone or inherited disorders of androgen receptors. Although rare, multiple tropic hormone deficiencies can also result in male infertility. An example is idiopathic hypopituitarism of childhood, which causes multiple hormone deficiencies, leading to growth retardation and delayed puberty. Other causes are pituitary diseases, which include pituitary tumors, metastatic tumors, cysts, irradiation, and infiltrative and infectious diseases. These result in secondary hypopituitarism, which leads to hyperprolactinemia and decreased testosterone secretion. Male infertility results from a wide range of causes, from genetic abnormalities to acquired conditions, including hormonal imbalances, physical dysfunction, and psychological disorders. The resulting abnormalities in sperm production, testicular function, and sperm transport or delivery affect as many as half of infertile couples. Because some conditions are not treatable, determining the cause is important in selecting appropriate options for couples with male infertility. Hopefully, this module has enhanced your knowledge of the abnormalities in male reproduction and causes of infertility. And you will be able to apply this as you care for patients in reproductive health settings.